Kaylee, if you can send out a note to everybody and let them know that the slides will be available after the session today, or actually I think we can probably post them online right now for folks who are interested at www.ehidc.org, ehidc.org. So Claudia, are you there?
I am.
How about a couple of Thanksgiving jokes?
I would love to hear some of your Thanksgiving jokes.
Okay. While we're waiting, what do you call fake sweet potatoes?
What do you call what sweet potatoes?
Fake sweet potatoes.
What do you call them?
A yam scam.
Oh.
For you folks playing at home, if anybody's got a good dad joke for Thanksgiving, feel free to submit it through chat, and the winner will get to be featured on our webinar today. What do you call a turkey on the run? Anyone? Fast food.
Oh, God.
That one was really bad. Okay. I like this one. What do you call an evil turkey? Poultrygeist.
Oh.
Oh, God.
Hey, Jen, there's some jokes coming in through the chat.
Oh, there are jokes coming in. What's the key to a fantastic Thanksgiving dinner? I'll tell you later. Thank you, Kate. That was a good one. Actually, turkey is the key. Turkey. T-U-R-K-E-Y. I guess if we have to explain it. What did the turkey say to the computer? Come on, you guys. You can figure this one out. You're techies. Google, Google, Google. All right, we've got about 1 more minute to kill here. If anybody wants to share their favorite jokes online. Oh my gosh, some of these are a little bit inappropriate that are coming in through the chat. Why did the pilgrim's pants keep falling down? This is from Josh. Because their belt buckles are on their hats.
It's probably time to start the webinar at this on that note.
I know, this is like, you know, you might want me to stop telling Thanksgiving jokes, but I just don't know if I can quit cold turkey.
Oh, but you have, oh. What about the one, what is the turkey's favorite dessert?
What?
Peach gobbler.
Oh, that is a good dad joke. Ooh. All right, anybody else got any final jokes here? All right, well, why don't we get started? Thanks for putting up with our silly jokes today on Thanksgiving. This is Jen Kovach-Bortnick, CEO of the eHealth Initiative here in Washington, D.C. We are delighted to have you join us today for our pre-Thanksgiving webinar focusing on artificial intelligence. And we're so lucky to have 3 great experts with us here today. David Cohen, who's the Vice President at Cerner, Lindsey Jarrett, Dr. Lindsey Jarrett, who's lead strategist at Cerner's intelligence organization. And then Matthew Keating, who's the director at Booz Allen Hamilton. And all 3 of these folks have done a lot of amazing work around artificial intelligence and machine learning. And we've been lucky enough here at eHealth Initiative to get to know these folks and the work that their organizations have been doing over the last several months. So we wanted to share some of that with you here today. Next slide. So right now you're all muted, as you probably figured out, but we are still taking jokes through the chat feature and questions through the Q&A feature. So if you have any questions for any of the panelists today around artificial intelligence, go ahead in that, you'll see a Q&A at the bottom there and submit it through the Q part of the Q&A chat box there, and we will take your questions at the end If you have any technical difficulties, just use the chat box, not the Q&A box, but the chat box, and Kaylee and Emma here on our end in DC will respond to you as quickly as possible. And of course, the overwhelming question, yes, the slides are available for download on the Resource Center right now, or you can just go to our homepage, www.ehidc.org. Next slide, please. So here's a copy of our mission there for those of you who are not familiar with the eHealth Initiative and Foundation. We are an awesome organization here in Washington, D.C. We've been around for 19 years, and we work with an incredible group of stakeholders from across the spectrum of healthcare, identifying best practices, sharing best practices, and convening executives around best practices. And today is a great example of that, where we're going to share best practices around artificial intelligence. Next slide, please. This is just a sampling of some of the folks that we work with through our membership and through our programs. If your name is not on this list and you would like to be, we would love to have you involved in our activities. So feel free to give myself an email or Amy a ring at Amy, A-M-Y, @ehidc.org, and we'd love to get you involved with our activities. Here's a sampling of some of the programs we're working on right now. We're going to talk today about artificial intelligence, but we have a lot of other things going on right now. A lot of work around data governance, clinical data driving success in value-based care, population health, electronic medication adherence, and we're doing a lot of work lately around prior authorization and trying to streamline provider workflow and the prior authorization process through some of the technology that's available right now. And then addressing privacy is another huge area that we've got a number of different work groups meeting on and talking about. So these are just a few examples of the work that we're involved in. Again, we would love to have you engaged in our work. And all of our work, lucky for you, is available online in our eHealth Resource Center. We are a nonprofit, so all of the deliverables and the reports and materials that we develop, survey results, go online through our eHealth Resource Center. So you're going to hear today about 2 different reports, and those are available through the Resource Center. I want to encourage you to jump online and download these 2 reports if you have not already. One is on artificial intelligence in healthcare that we worked on for a couple of months with Cerner, and then there's another report, The Machines Are Here and Improving Healthcare, really looking at machine learning that we worked on with Booz Allen Hamilton. And we're going to talk about some of the things that are in these reports today. There are great examples in this report about what's happening in the field right now. And one of the reasons I really like these reports is because we focus on all different types of organizations in healthcare. We're not just talking about the big organizations, big hospital systems, but we've got some great examples from some smaller groups, smaller health systems, smaller hospitals, and really I think proving that you can do this in many different ways, in many different places, and have success. So artificial intelligence really isn't out of reach for a lot of us. Next slide. So I'm really excited now. We're going to turn it over to Lindsey and David, who are going to take us through the first piece here. We're going to be talking about artificial intelligence in healthcare, and we'll hear some other examples as well. So Lindsey, David?
Great, thank you so much. This is David Cohen. I'm Vice President at Cerner, responsible for our machine learning and AI efforts.
And I'm Lindsey, Jarrett, and I work on David's team, and I am lead strategy for patient safety and quality.
Great. See the next slide, please. Okay, so I thought I would start us off today by, one, providing a good book recommendation for Thanksgiving, which is The AI Advantage by Thomas Davenport. It's a really good, quick read, and I'd highly recommend it to everyone. And one of the things that Dr. Davenport talks about in his book is for companies that are looking to get started with AI or machine learning, how do we want to think about that process of getting started? I think it's really easy for companies to jump right into wanting to talk about technologies, whether it's machine learning, deep learning, voice, vision, But really a better framework for thinking about it is to understand what some of the business opportunities are for AI to address across your organization. So the book frames out 3 different kind of buckets of business opportunity for this type of technology. The first one is around robotic and cognitive automation. So how are we thinking about leveraging AI to automate some of our core business processes? When I think about that in terms of healthcare, what immediately comes to my mind is thinking about how we can leverage AI to automate some of our revenue cycle type workflows. So I think, you know, when you think about the breadth of the healthcare that Cerner's in, we think about clinicals, population health, operational, and also revenue cycle and financial management. And I think for robotic and cognitive automation, revenue cycle is a great place to look in terms of automating things like billing, claims denial management. The second area is around cognitive insight. So, you know, over the course of the past 20 years, healthcare has done a really good job around digitizing core processes. As a result, we've generated large quantities of data that are perfect for doing data analysis on and looking for opportunities to gain new insights and develop new cognitive interventions within the healthcare space. The third opportunity is around cognitive engagement. I like to think about cognitive engagement as opportunities for AI to help to facilitate clinical type workflows. So when we think about technologies like voice and video, how can we leverage those different technologies in clinical settings and clinical environments to help to facilitate and augment clinical workflow and clinical understanding? So let's go to the next slide, and we'll talk about one of the specific use cases from the paper that was referenced earlier. So one of the opportunities in thinking about, you know, the business opportunity to leverage AI was to think about falls and falls risk. So every year between 700,000 and 1 million people in the United States suffer from preventable falls in the hospital. Each one of those falls can be attributed to, I think some of the studies that I've read in the past couple of years have been about a $15,000 average cost for an acute fall within a hospital. So, you know, like everything in healthcare, when you do the math, it becomes pretty high magnitudes of opportunity. So 2 years ago, Cerner partnered with one of our clients in North Carolina, Atrium Health, to really think about how we can address this falls problem. And AI became, you know, entered into that conversation as a really great opportunity to help us think about how we can solve this problem. As you know, many healthcare organizations hire sitters today to sit in patient rooms to help to monitor high-risk falls patients. Additionally, they're using restraints and other types of physical devices within the room to manage falls. And we found opportunities to leverage AI to help to address this problem. So let's go to the next slide, and we'll talk about kind of how opportunities to leverage AI for this specific scenario. So in working with Atrium, we developed a solution called Patient Observer. And what Patient Observer is inside of an acute care room, we put a Kinect sensor. Kinect sensor, if you're not familiar with it, is a sensor that was released by Microsoft, recently deprecated. They've come out with a new sensor. Microsoft Kinect provides the ability to have 3D sensors as well as video and audio within the exam room. And we're using this technology for nurses to monitor several beds at the same time. So many of our nursing stations, we've got 2 monitors that would give nurses the ability to monitor 12 beds at a time, compared to having sitters in every one of those rooms. With this technology, we're able to provide a video feed that goes directly to the nursing station. And what's really innovative about this is leveraging the 3 sensor capabilities to create a skeletal tracking outline of the humans who are in the room. This is a pretty hard AI problem to solve, particularly when we think about patients who are lying in beds in a supine position, potentially under covers or blankets with tubes plugged into them. So it was a pretty hard technology solution to solve, but using AI technology and capabilities, it created a very viable monitoring type of solution. So the way it works is once the patient is lying in their bed or in the chair, a nurse would create a quote virtual boundary around the patient that would then monitor the patient for them leaving that virtual boundary. Once they leave the virtual boundary, it would fire an alert or alarm into the nursing station. You'll notice on the view, it's showing that kind of a red display to notify the nurse that the patient's left that virtual boundary. The skeletal tracking technology is actually very, very accurate. So we can get down to the finger or the digit level with this. And what that enables us to do is to then not just create falls types boundaries, but also use this technology to monitor other things that we might want to know about the patient. For example, if they're a suicide risk patient, we can monitor them for their hands approaching their neck or other type positions. If they're on tubes, we can monitor them for any activity that might indicate they're attempting to pull tubes out of their arms and other things. So what's really neat about this is we came at it with, trying to solve one potential business problem, and through the project, we identified several other opportunities with the technology. Now, once the alarm goes off, the other neat thing about this is it enables nurses to go right into a bidirectional conversation with the patient. So that's the benefit of two-way voice as well as a bidirectional video feed. So let's go to the next slide, please. So I mentioned in addition to managing falls risk, we identified several other use cases for this technology. So one of them is, we talked about safety zones. Another opportunity is to manage patient elopement. So we can detect if a patient is leaving the room. We can also detect if new people are entering the room, so unexpected visitors and other things. All right, next slide, please. So if out on Cerner's website, we have several client testimonials in addition to Atrium Health. We also deployed this solution with Mission Health in Asheville, and we've seen very positive results from this. So over a 3-year period of the study with Mission, they reduced their falls rate down to 0 for that three-month period of time, and they're projecting fairly significant cost avoidance opportunities. And again, when we think about healthcare as a whole, when we magnify this across the system, the dollars that we're able to manage and take out of the system are pretty substantial, in addition to the quality benefits that our patients are yielding. All right, so next slide, please. And I'll turn it over to Lindsey to talk about some of our other efforts around machine learning.
Okay, great. Thank you, David. So we've come a long way in understanding data and how to use it in healthcare. We're in a shift. We're moving away from being reactive and rewarded for volume, and we're really moving into a proactive space. So looking across the care continuum, focusing on safety and quality, and really centering around the person and care team. So at Cerner, we're leveraging AI and machine learning to identify risk, to decipher appropriate interventions, so using clinical information to guide that, exploring care plan options, monitoring and supporting those at high risk, and detecting risk factors for health management. But we really must think about how we fulfill on the quadruple aim for some pretty big problem areas. So I'll give you a couple of examples of where I'm working in this space. So some of the work that I'm doing is focused on the opioid epidemic, which causes about 115 deaths per day in the US, and in infection control, specifically related to hospital-acquired infections, which impacts 1 in 31 hospital patients every day in the US. So in the realm of opioid safety, we're partnering with groups internally and externally to evaluate how intelligence can assist in identifying those at risk for substance use disorder, provide guidance for care planning, including medications, monitor and track activities related to those at risk, and evaluate outcomes for those identified. Infection control is very similar in process, but each problem has a lot of dependencies on people, process, and of course, data. It's not simply about pulling or acquiring a data set anymore. There's really a lot of work to understand what we need for the problem, the tools required to provide a solution, and how our users will interact with our intelligence offerings. Specifically in the clinical space, there are so many opportunities for AI and machine learning, but there are also so many great things already happening that we need to take time to learn from. To fulfill on AI in the clinical space, we really must combine AI methods and systems with the human clinician to advance the delivery of care that outperforms what either can do alone. Thank you.
Great, thank you so much, Lindsey. Okay, well, let's hold the questions for the end. We've got a couple of questions coming in already, but I'd like to get through the second part of the webinar first, and then we'll do the questions at the end. So just hang on, folks. So I'm going to turn it over now to Matt Keating, who's with Booz Allen Hamilton. And Matt, you want to continue on?
Sure. Good afternoon, and thank you for the introduction. So with this presentation, I'm going to try and accomplish two things. First, I'm going to try to address the hype around AI right now, and so I'll spend a little bit of time discussing the state of the technology and talk about where AI presently works and where it does not. And then with that level of realism as a backdrop, I'll probably discuss a handful of real-world AI use cases in healthcare specifically. And you know, one thing to note on terminology, when I'm speaking casually as I am today, I will often use the terms AI and ML or machine learning synonymously. So if that happens, just know I'm really talking about the same thing. So next slide, please. So let me start by talking about the excitement around AI. And as we all know, a lot has been said about AI of late, and it feels to me that we must be at or near the top of the hype cycle. And I hope we are, to be honest with you. I hope there's not room to go up from here. And to illustrate this, you know, there's two headlines on the screen that were published one day apart in April of this year. And you'll note that both of these headlines are from reputable sources. So the first one reads, AI could lead to a nuclear war by 2040, think tank says. This was published by CNBC on the 25th of April. The very next day, Bloomberg published an article entitled, AI will give us better French fries. And so I'm a staunch believer that AI is a transformational technology, but I like to start my talks with this slide because it serves as a pretty good allegory for just how easy it is for the uninitiated to get lost in the hype. So what I'm going to try and do is I'm going to try in this presentation to not only stay away from hype, but also separate hype from reality. So if we can go to the next slide, please. It's undeniable that machines are increasingly doing the tasks and making decisions that were historically reserved for humans. And so on the left-hand side here is a list of some of the tasks that intelligent machines are doing today, right? They're responding to our commands, which is great. I'm sure everybody on the phone has asked Siri or Alexa for the weather or to set a reminder, and that's very convenient and nice. We have unmanned vehicles on our roads that may be convenient and nice or scary, depending on your point of view on that. Of course, as you guys are well aware, we have machines helping diagnose and treat disease. And you know, I think one that sticks in my mind, an example of this, there are many, but it's been over 2 years since Stanford has been working on an algorithm to diagnose skin cancer, as an example. We know machines are now producing different mediums of art, And you may remember a while back in the news, Google's DeepMind was getting a lot of press for its software that plays the game Go and was beating the world Go champion. But today there are a whole host of things that machines can't do, and it appears to me that in some of these we're pretty far away from it as well. You can't have a conversation with Siri, as an example, right? And frankly, using Siri is frustrating, and at best you can kind of bark some commands at it. I have a friend that has ridden in the Google car, and he told me that it was pretty fun to ride around the test track in the car with no steering wheel, but he also assured me that he would not want to be in that car in Manhattan during rush hour when it was snowing. And machines can't understand human emotion or humor. They can't invent games, and they can't teach themselves new skills without the help of humans. And so I would just maybe looking at these two boxes, these are not static. These are things that are going to change over time. This is just a snapshot today. And I would imagine that the first thing that will jump from the right box to the left will probably be machines teaching themselves new skills. But if you look at these things sort of at a macro level, I think you could summarize this by saying machines are good at doing a lot of things, but they're quite narrow in what they do. So let's go to the next slide, please. And so, I mean, to state the obvious, machines can learn, and sort of that's important because if we take an academic point of view on this, the foundation of intelligence is learning, right? Everybody on this phone call, all the machines, they perceive, they reason, they draw a conclusion. And it might be good to think about this in the way that, and maybe start thinking about this the way that humans learn. Humans learn in two ways. They do what we do what we call direct learning, and we do indirect learning. Direct learning is when somebody asks you what the capital of the United States is, and you say Washington, D.C. You learned that directly because somebody told you, or they told you directly that the capital of the U.S. is Washington, D.C. Indirect learning is when you learn something, but you don't know how to do it until you try. So bike riding is a great example of indirect learning. So machines can reason the same as humans, but they learn very differently. Machines learn in 5 different ways. And so when you're out there talking to people in the industry and they're talking about the next algorithm, I mean, there's probably thousands of machine learning algorithms out there. But at their core, each algorithm falls into one of these 5 boxes. And so, you know, how I think about these things, and when I'm talking to the practitioners who say, yeah, there's this great new algorithm for vector machines or something like that, I always bring it back to this slide in my head and try and boil it down to one of these 5 things so it's more understandable to me. This is kind of like your decoder ring, so to speak. But I bring up these 5 methods of learning, not to lecture on the methods that computers use, but to illustrate a point. And at Booz Allen, when we talk to our clients who are trying to solve a complex problem or trying to build a service offering around AI, we will often tell them that if they want to be really relevant in that space and successful in applying AI to their business, they really do need to understand how humans and machines learn and know which asset can be best deployed to the various aspects of their mission. And I think that's critical. The other thing that I'll just mention here, it's not on this slide, but as I was talking, I was thinking about it. I often get asked, what are the things that are fueling AI now, or how, what makes a good AI use case? And I think there are typically 3 things that are sort of pushing AI forward right now. It is access to generally affordable, large or hyperscale hardware, lots of research and development in these new algorithms, and then most importantly, more labeled data than ever before. And I think probably many of us lived sort of the hype around big data. But big data alone is not that interesting to a computer, but labeled data really is. So let's go to the next slide, please. So I was just going to rattle off a couple of use cases that I thought might be interesting to this group, and some of them are general, and then on the right-hand side, I've listed a few that are specific to health. So, and these general ones, they're probably listed simplest to most complex. So we hear a lot about object detection. And so we hear about picking out cats or people or vehicles in images and videos. And I would say that the ML community has gotten pretty good at that. We can train algorithms now to generally pick out buses or airplanes or whatever it is from images very well. Now, it's different and harder, as we'll talk about in a minute, to diagnose maybe cancer from an image, but general picking out of objects is pretty well established and quite easy to do. Text spotting is maybe a little bit more sophisticated, and there's kind of an interesting use case about this. The NHL in last year's playoffs, I guess maybe 2 years ago, their playoffs, they were trying to figure out how many times an advertisement that was on the wall around the hockey rink, how many times a single advertisement was shown on TV. And so they built an algorithm that analyzed the video and looked at how often a particular ad was on the screen. And interestingly enough, they were selling ads. The most expensive ad was at the center line, but as you looked at the percentage of time on screen, those ads that were in the corners were often the ones that were shown most often on the video. So a couple other things that are happening in the industry today, learning from a new environment. This I find really fascinating. NVIDIA has a robot called Isaac that is doing, I think, remarkable things. So if you haven't heard about Isaac and you want to spend, a couple minutes on YouTube seeing something that I think is really interesting, please feel free to go Google Isaac. Isaac is an AI robot that has a physics engine. And what you can see on YouTube and other places is that the team that was working with Isaac gave Isaac a putter and a golf ball. And they basically told Isaac, okay, which side of the golf club to use, and hit the ball and try and get it in the cup. And you can watch Isaac's sort of trial and error. And at the end of the training period, you can see Isaac sinking trick shots on the golf course, which is pretty interesting. Projection is another technique that we see a fair amount that people are using in AI right now. We see this a lot in the military arena, where the military may be trying to train an algorithm to do object detection, like in the first use case here, and they want to do object detection maybe in video, but they don't have any existing pictures of the objects they would like to detect. So maybe they only have the blueprints for an object. So they're using ML to actually create synthetic pictures of these objects and then training their algorithms on the synthetic images, which is pretty fascinating, sort of like layered ML AI approach. And we do see this, and I'm sure maybe others on the phone have seen this more than I have, but I've only seen this once or twice, but I have seen people in the health space using this to take a two-dimensional image or video and try to add that third dimension, like as in a heartbeat. So I would welcome anyone on the call who has maybe experienced this to comment at the end, because I don't have a lot of experience with that use case, but I know it does exist. Adversarial machine learning is something that a lot of academics and the military is using right now, where they're adding noise to an image or video to trick the algorithms. So it is kind of funny if you want to Google sort of tricking ML, you'll see some information from like Stanford and Berkeley and Dartmouth and others, where they're taking pictures and they're just injecting a little bit of noise into the picture, and the algorithm's predictions flop wildly, and it's a pretty interesting thing to think about. And then finally, what I think is really fascinating right now, some of the research that's going into understanding human behavior. And it's not really trying to understand behavior, it's actually just trying to identify behavior. So people are parsing videos right now to look for things that are out of the norm or out of the ordinary. So like, for example, they're analyzing airport video to look for suspicious behavior. Someone may be acting out of the norm. So these are all things that I would put under the real category and the now category. And then sort of applying that to health, I'll just talk about a few more use cases. This image-based disease detection, we talked about that a little bit. In 2017, Booz Allen and Kaggle teamed up with the National Cancer Institute to put on our annual Data Science Bowl. And I guess I'll take this time to shamelessly plug the Data Science Bowl. If you're not familiar with the Data Science Bowl, it is probably the premier data science competition. And it's produced by Google and Kaggle. And each year we take a social issue and we attempt to harness the power of Kaggle and the collective ingenuity of all the data scientists around the world to solve that problem. So we've done things on plankton in the ocean. This was for the National Cancer Institute, and a lot of other good causes. So the goal of this particular event was to create an algorithm that more accurately determined when lesions in the lungs were cancerous. And the result of that competition was an algorithm that decreased false positives by 10% over current best-in-class approaches. So that's pretty interesting. Another application in health that I'm aware of is Dictation Lens. This is a solution that Booz Allen developed for emergency departments to help providers that have limited time sort through their patient data. And this solution, which I might add to our Cerner folks, was a finalist at the Cerner Code App Challenge when we introduced it. So we're pretty proud of that. It scans the patient's EHR, pulls out keywords like high-risk medication, conditions, whatever else, and then makes that corpus of information much more approachable to the provider. A couple other things in the health space, speech analysis. This is something Johnson & Johnson is working on quite a bit, and it's quite fascinating. They're developing audio algorithms that analyze linguistic diversity in patients to help diagnose Parkinson's, MS, Alzheimer's, and other neurological diseases. I won't continue to list all these. I think I'm using up most of my time, but Christus Health and others are doing some great work with predicting length of stay and readmissions. There's people working on propensity to pay models. And then there's a lot of work in the payer side of healthcare to detect and mitigate against fraud, waste, and abuse. And we have a number of clients that are doing that. So, well, let's go to the next slide, please. And so, finally, I think I'll just kind of wrap up with a few points on AI and machine learning and how it compares to humans. So one of the things that's really notable is machines do lack judgment. And so if you kind of think about it, society is built upon a contract of expected behaviors, and humans are complex, we're inefficient, we're emotional. And as of yet, we don't have an AI system that can broadly respect and fit into our social norms. And I don't know, maybe that'll happen soon enough, but we don't have that today. And a specific example of this actually is I was talking about looking for suspicious behavior at an airport. There are systems right now that are monitoring movement inside of transportation hubs, and they are finding and identifying people that are acting maybe abnormally at the airport. Maybe the machine is good at finding people who are, for example, standing still in an area where others are moving, but the machine can't say if the lack of movement is good, bad, or indifferent. And so there really is a context there that the machine doesn't quite understand, and that's that's what this next point says. For machines, their context is strictly mathematical, and for better or for worse, they don't have a broad set of experiences to draw upon. For any of the policy folks on the line, AI as AI becomes more pervasive in our lives, the need for ethics and privacy will certainly become increasingly important. And then I mentioned before about big data itself not being interesting, but labeled data being interesting. I would say this is for those companies and people who are interested in getting into machine learning. I would say this is a call to action that you really do have to have labeled data in order to make use of your data. And please, if this is an area you think you're interested in, start now. Data quality and data labeling is going to be paramount, and it will continue to be. And then finally, I'll end with this sort of interesting juxtaposition I see in how, let's say, our commercial folks and government folks tend to think about data. In the government side, and I'll cite NIH as maybe the poster child example, they are running as fast as they can towards open data initiatives. If you're familiar with the NIH Data Commons initiatives, the idea is bring together all this research data as a force multiplier for scientific research. But interestingly, and that's great, and as someone who is a consumer of the byproducts of life sciences, I really do want that. But our commercial typically has a very different stance because in order to become superior in the AI ML game for a commercial company, you necessarily have to have better data. And so it's really interesting thing to think about when talking with various stakeholders and people interested in pursuing AI and machine learning capabilities. So I'll stop there. Thank you.
Great. Thank you so much, Matt. Well, I want to thank both of our speakers. We've got some really good examples here and a number of questions to ask each of you. Matt, just to pick up on one of those last points that you were just talking about in terms of labeled data, kind of transforming big data into useful data, I guess. One of the things you talked about in the report was about curated data and data that's, really, I would say, I guess, clean enough or good enough to use for artificial intelligence. And then you just mentioned about how we really need to focus on kind of labeling data right now. How do we move forward with that? Is that something that providers and payers, should be doing in a consistent way? What's the way forward in terms of, having data that works for all of us?
Sure. Well, I mean, industry consistency would be fantastic. I think typically when we're working with our clients, we would consider it a win to get standardization and cleanliness and labels within a single organization. So I think we have to run out on both. I think what comes to mind to me is getting labeled data is laborious. And I haven't figured out a way to get around that. And if anybody on the line has great ideas, I would love to hear them. But I think back to some of the work that we did in fraud, waste, and abuse for CMS, where we're looking at fraudulent, it was SSA. For SSA, where we're looking at fraudulent new disability claims, and really we have no way of determining what's fraudulent and what's not, at least initially, without asking a human. So we partnered with the folks at the SSA to go label a number of their fraudulent claims so that we could train on those models. And I think it's the same for anything.
David or Lindsey, can you comment on the labeled data issue?
Yeah, I would agree with Matt. The best answer would be if we have strong industry standards that are defining ontologies and terminologies for healthcare. So, for example, we've got within Cerner Intelligence a significant group of people that are focused on mapping our clients' data to standard terminologies. Those standard terminologies would be things like SNOMED, LOINC, CPT, other things. The value and benefit of that is not just for AI and machine learning, although that's certainly a really important element of AI and machine learning. As anyone who's tried this knows, our data scientists spend an inordinate amount of time on data cleansing and data normalization. But for healthcare as a whole, this is vital to be able to realize what the industry is trying to do with interoperability and population health management. So being able to send data in and out of specific, EMR domains, I call that data liquidity, really requires that we have data mapped and data normalized for it to have meaning as it's flowing in and out of those different healthcare domains. So it's something that becomes really important. We try when and where we can to map to industry standards, but those industry standards certainly need a lot more love and attention. I think, we frequently submit opportunities to expand those standards for our various client use cases. But again, I think it's something that's really important and really essential to achieve all the things that we want to achieve, both from machine learning and from an interoperability perspective. I think FHIR is going to force the hand on some of this as well.
Mm-hmm. Just to stay on that point for just one more moment. So, having access to good data is really critical to be able to do AI, and it's not available to everybody. So what types of data sets are people using right now? Is it primarily EHR clinical data? Is it claims data? What are the data sets that you see most often, or the data sources you see most often being used around AI?
So this is Matt. I'll say it was all of the above that you just mentioned. EHR, and I'm sure the folks at Cerner can probably talk about that even more intelligently than I can. But we're doing some work with imaging, like the American College of Radiology, to apply some machine learning to help diagnose various diseases within the images. I mentioned Johnson & Johnson is using audio data. In the military space, there's a lot of video processing. So I don't think that, I can't think of a particular data type that is, most popular. I think they're equally spread out across all data types.
And this is David. I think for the purposes of research, we're seeing a lot of organizations using publicly available data sets, things that might be available from I2B2 or Kaggle or other data sources like that, coming from NIH as well. Within our client community, specifically healthcare organizations, we see many of them doing research on their own populations or their own internal data sets. I think, within the healthcare domain in particular, data rights and sensitivity and privacy become something that is important to be considered and factored in, particularly where, we're talking about data sets that contain PHI type information. And that's something that, we as an organization are very sensitive to, making sure that we're honoring HIPAA and PHI type information. But where we're able to obtain data rights, particularly data rights that are coming from a consumer, the consumer himself, we're able to do more interesting thing with cross-population data sets. But for us, it always starts with making sure that we've got the proper data rights across those populations.
Mm-hmm. Got a question for Lindsey. Lindsey, can you give an example of how AI is being combined with the human clinician?
Yeah. So I'll give it some examples inside of the machine learning space. So with our machine learning algorithms, we make recommendations to enhance decision making. So we don't automate those clinical decisions. We don't force the clinician to make those decisions. We put in recommendations and risk scores and those sorts of things. But working alongside clinical rules and evidence-based treatment plans, we leverage that learning to understand how those actions relate to outcomes. So, for example, we've done a couple of things recently. We've used a technique called journey mapping, which actually is inside of user experience or like human factors related work, to understand the continuum of care. And we actually do that with clinicians. And that's really to understand, what we used it for is to understand the barriers in C. diff prevention prior to actually building anything in machine learning or building anything in that space from an intelligence standpoint. And then for opioids, which I talked a little bit about before, we also plan to leverage what we actually build for clinical decision support. So those kinds of things are being updated and created for opioid safety, and so we'll leverage those for learning and for algorithm development. So it's more like an augmented practice, which is in line with what AMA wants us to do in this space as well. But just so those are some examples of where we're working in that space, but we definitely have room for growth.
That's great. Thank you.
Yeah.
So we've got a lot of questions about the difference between machine learning and AI. And Matt, I'm not sure if it was you who said that machines can learn, but humans need to teach them. Can you talk a little bit about what's the difference between machine learning and AI?
Sure, I'll do my best. I think if you look it up online, I think you'll find people that are very passionate about these definitions. I am not one that is. I would say it's generally accepted that machine learning is a subset of AI, or AI is a superset of machine learning. And I guess the way I would characterize it, and this is by no means definitive, is I would say AI is a broad set of technologies, and I think it's at its core, AI is just trying to perform tasks that are characteristic of maybe human intelligence. And so this could include things as like rules engines or expert systems or something like that, while machine learning is just a subset of AI where it's focused on teaching the machine a particular behavior or a way to reason about a particular set of data. And while probably not a true definition, I would say that to me, machine learning is also characterized by the fact that the machine would modify itself based on more data, or could modify itself based on more data. And you wouldn't find that in all AI applications, like, for example, rules engines.
David, do you want to add to that? The difference between ML and AI?
No, I think that's Matt did a great job with that. One thing I'll further mention is the realm of deep learning, which I think is viewed as a subset of machine learning as well. That's really focused on reasoning across very large data sets.
Great. Can either of you talk about, or three of you, artificial intelligence opportunities for healthcare systems beyond clinical settings, so with customer experience or human resources? Any examples there?
Well, I'll talk about one, and that is, and this is very recent in my mind, we recently met with the CMS, and as people may know, they operate a call center out of CMS, and that handles 1-800-Medicare, that handles Medicaid calls, open enrollment for the Affordable Care Act, et cetera. And they get about 4 million calls a year. And they're really interested in improving the customer experience, and how do they get better outcomes for the customer? I mean, not clinical outcomes, not health outcomes, but how do you answer the customer's question more quickly? And in doing so, how do you drive down cost? And so we've been working with them to look at some case studies around how to improve that experience. And that's just one aspect that's not clinical.
Lindsey or David?
I don't know if, and maybe David can tag on here, I don't know that we have any examples specifically, but I think if the people on the call are interested, I think a really good learning exercise for in the HR space is the recent, like, Amazon, when they were creating that AI recruiting tool for their engineers. I think I mean, you could just Google it. There are tons of information about it. But they've, like, scrapped it. They've seen a lot of bias. And so I think we're starting to just learn how just a lot of the variation that we have in recruiting practice, and especially in tech. So I think that's a good example. It's not our example, but I think it's a good example for people to look into if they want to just see about lessons learned and how we can move forward.
That is a perfect example. I'm glad you mentioned that. David, picking up on your deep learning response before, can you talk a little bit more about your thoughts on deep learning in healthcare, especially because the models are black boxes and predictions are often not explainable?
Yeah, I think that's a really good question, and quite honestly, Cerner as a company, we're still evaluating, how much or little we want to use deep learning. Our approach right now, at least, as we think about AI broadly, is to adopt a human in the loop model, to where we're not at a point where we're comfortable really fully automating many decisions, but really thinking about how we can leverage these technologies to augment clinical decision-making and decision-making in other realms as well. So, for example, we're very heavily focused in hospital operation realm and revenue cycle realm as well. But I think it's certainly something that needs further discussion and investigation, and has been a focus of many of the conversations that I've had with our clients, particularly, as we propose or suggest different types of clinical decisions to caregivers. I think when you think about, a philosophy or paradigm of maintaining a human in the loop, it's important that we're able to articulate the why. So why are we making certain suggestions or certain recommendations, so that the clinician is able to adequately reason against that and use that information as one tool in their toolbox, in addition to their own training and experiences and other information that's in the EMR or other information sources, to be able to use that to make their own judgments about what the right diagnosis or treatment is for their patients. So I definitely agree with the concern, and I would say that I have not formulated a formal opinion on that yet, but it's something that we're still evaluating. I would say as deep learning starts to develop and grow more as a potential tool that we might want to use in clinical environments. I do think that when we talk about non-clinical environments, so things like operational predictions or financial predictions, we're maybe a little bit more comfortable with that type of black box reasoning, just because the stakes and the risk may be a little bit lower than they are in the clinical realm.
Great. Another question, do either of your groups have experience with de-identifying patient data so it can be used for research purposes with AI?
Yeah, at Cerner, we do that quite often in working with our clients, in working with them to do clinical research where PHI is involved. We have our own internal tools for de-identifying patient information that's coming from EMR type data sources. I also know that there are several tools that are coming available from various cloud providers that will automatically de-identify unstructured data as well. So if you think about capabilities that cloud providers might offer around NLP to be able to use that type of technology to identify PHI information and then be able to hashtag or denormalize that PHI type information. But I'll mention that, you know, it becomes important to, de-identification becomes particularly important when you're thinking about merging two data sets. So for example, if, you know, entity A is looking at doing a study with entity B, being able to de-identify that information becomes particularly important.
Great. Matt, any comments on that?
I would say personally, me and my team, we do not have any real experience with de-identifying data. We are more consumers of de-identified data, but more broadly at Booz Allen, we have helped customers deploy systems where they are information sharing systems that require data privacy.
And one more question for Cerner. Do you have any experience using the EHR data where you've used AI and documented or demonstrated reducing the cost of care? For David or Lindsey.
Yeah, I mean, so I think if you go back to the examples that we referenced earlier related to managing falls risk, that's one such example where, you know, we've leveraged AI technology to reduce falls risk and also reduce the cost of managing those falls by eliminating sitters and consolidating those operations for a particular nurse. I would also mention that some of the, you know, risk predictive type models that Lindsey has referenced also have yielded fairly significant benefits across our client base. So one example is about 3 or 4 years ago, we released free to all Cerner clients a sepsis risk predictor model. That model has been out and available to our clients for a number of years and has yielded significant results in early detection of sepsis, which, you know, in turn has dramatically improved both quality of care through early detection and intervention against sepsis, but also has taken the cost of, you know, the high cost of then treating and managing septic patients out of the healthcare system, you know, as a whole for our clients. And I think that there, you know, if you look across the opportunities, there are significant opportunities to scale that across different types of conditions and modalities. So I think we've got really good examples, which would lend us to believe that, you know, there's great opportunities to further scale that up and out.
Mm-hmm. Great. Well, I know we've gone over by a few minutes, but I do want to thank our panelists today, our speakers today, for joining us on this pre-Thanksgiving webinar. We've got a number of questions left, and we will do the best we can to send out some Q&As to participants today. We're really delighted that everybody was able to join us today. And again, I want to thank Cerner and Booz Allen, David, Matt, Lindsey, for your help today. I think we had a great event, and I want to wish everybody a very happy Thanksgiving. Thank you so much.
Thank you.
Thank you.
Thank you.
Bye-bye.